The quality of patient health records kept by general practices is an important factor in safe and effective healthcare. And the primary purpose of a clinical health record is to hold information about a patient that's required for the effective care. Accurate and up-to-date patient information supports appropriate clinical decisions. So, hi everyone, and look, thank you all so much for joining in to part one of our consistent data quality, ensuring clinical safety standards for your organisation. My name is Nicola Graham, and joining me is my colleague Brianna Mewad. We both have extensive experience in the health system and have both been practice management positions. Now, we are also very happy to introduce to you all Peter and Patricia, who will be presenting with us and also participating in a panel discussion at the end of the webinar. So that'll give you opportunities to ask your questions and we'll be able to address those. Now, I'd first like to introduce you to Patricia. Patricia has been a practice manager for 13 years and has a really high interest and strong in encouraging data quality within her practice and building a great practice team and ensuring that they all work well together. We've also got Dr. Peter Del Fonte, and he's a GP in Adelaide, and he has expertise in digital systems, data governance, and change management in general practice. Now, his experience as a leading GP in regional health associations has led to development of digital tools that support coordinated and integrated care, and of course the quadruple aim, as well as data analytics and mapping tools for population health. All right, so first I would like to acknowledge the traditional custodians of the lands we're meeting on, and we'd like to pay our respects to the elders, past, present and emerging, and acknowledge and extend that respect to other Aboriginal and Torres Strait Islander people and elders from other communities who may be joining us today. All right, so just some housekeeping. We will have your microphone on mute throughout the presentation, and you can ask a question at any time using the questions tab. Now, they will be answered, as I said before, at the conclusion of the presentation. Now, to collapse your go-to interface, there's an orange arrow, and just click on that and that will drop it away. Now, if you're having trouble and your screen and sound don't quite match, you may have some lag in your internet, and what you may have to do is exit the webinar and then come back in to restore that connection. Or you could simply try a different audio option. So tonight, we will have our cameras off for the presentation. We have had some internet connectivity problems, so we will have our cameras off initially, and then you'll see us again at the end for the panel discussion. All right, so the learning objectives for tonight, we're going to go through understanding the need to focus on data quality, recognise the role of medical terminologies, understand the importance and benefits of high quality data records, and of course, help you identify the clinical risks of having poor data. So for healthcare organisations, data is integral to ensure effective delivery of healthcare. Accurate data about diagnoses, medicines, immunisations, and the effectiveness of treatments is crucial to assist in maintaining and improving healthcare delivery. Digital health technology has the potential to remove barriers to service access and, for example, through the use of telemedicine to provide specialist care to remote or isolated communities. It helps improve continuity in patient care through the use of electronic records like My Health Record. It helps enhance clinical decision making and a system-wide response with real-time access to that health information between health services. So for your patients, digital health technology can enable people to help understand and take control of their own health and health information. And for you as clinicians, this technology can support improved interaction with patients, continuity of the care, and improved effectiveness, efficiency, and delivery of health services. The scope and use of digital health technologies is growing and changing rapidly here in Australia, enabling real-time information to be available to patients and to your healthcare providers. However, the rate of this change is not consistent or coordinated across our health system. The lack of systematic, standardised collection of data from primary care data relative to other areas of health poses a particular challenge. Now, this affects your ability to share information within and between systems and sectors to inform good patient care. Now, for patients, the quality of their health information kept by a practice can affect their health outcomes. Now, this information informs decisions about their treatment and it also facilitates continuity of care both within the practice and also between other healthcare providers. High quality records also make it easier for patients to access and understand their health information. For GPs, high quality health records allow them to effectively communicate with their colleagues and other healthcare professionals. It allows GPs to take full advantage of clinical information systems to more efficiently manage patient follow-up, and that would be through reminders and recalls, and for particular patient populations. GPs may also rely on health records defending against medico-legal claims. For general practices, high quality patient health data is becoming more and more essential for quality improvement activities. And it also allows a practice to better understand and identify its own patient cohort. And this supports obviously more effective healthcare delivery at both an individual and a local population level. So we have Peter with us tonight. And Peter, would you be able to discuss with us the benefits of having high quality data records?
Yeah, sure. Thanks, Nicola. I think the most important things of high quality data in your records is really around patient care. If you're going to provide comprehensive care as a GP, then you need all that critical information, particularly things like allergies, diagnoses and medications, and maybe past immunisations. We obviously may have other information around family history and that sort of thing, but the key thing is that health summary is most critical information. And the reason for that is we use that for making decisions about patient care, safety around medications that we may prescribe, and our clinical information systems that we use in general practice have a lot of inbuilt decision support, which rely on good quality data. Also, I think it's important as part of our professionalism, if we're caring for patients, that they I'm sure many of them assume that we have all their health information in one spot at any one time. And we know that we often have gaps in information for a lot of patients, but predominantly there's this expectation from patients that we have the critical information available in our systems. And we use that information when we're making referrals so that other colleagues or professionals or allied health that are involved in the care of the patients can have access to that same good quality data. So I think that's important. From a practice population perspective, you can use all that good quality data for when you're doing things such as trying to sort out how many diabetics you may have and how many are well controlled, who need to be recalled and that sort of thing. So from a practice population management, it makes sense to have good quality data. And I think the end point for most patients is that through that information that you have about the patient, when we're looking at transition of care, we often talk about care continuity. And part of that care continuity is information continuity. That information that is always available with the patient wherever they are in the health system. And we can contribute to some of that through our referrals, obviously, but also to things like the My Health record, if we upload a shared health summary, to make that available as a share document to wherever and whenever the patient may have contact with the health system. So I'll leave it at that. Happy to see what...
Yeah, thanks, Peter. And it really does highlight, doesn't it, that the continuity of a patient care does really require the information continuity to be shared and to be accurate. Thank you for that. So really then, if data quality improvement is not part of an overall and continuous focus on quality improvement, then your practice is unlikely to achieve sustainable digital health benefits. So in effect, your practice needs a culture of continuous improvement for these benefits to be sustainable. Now, we know the quality of a patient's health record is an important factor in ensuring safe and effective healthcare, just as Peter has said. So Peter, here we've got written, you can't manage what you haven't measured. And we do know that the quality of patient health records is an important factor in ensuring safe and effective healthcare. Would you be able to share a little more information just in relation to all of this?
Yeah, sure. I think that quote, you can't manage what you haven't measured, is an obvious thing. If you're in the management game, you're always measuring the logistics of orders, sales, and everything, and fine-tuning what you're doing in terms of delivering both efficiency but also accuracy in terms of what it is that you're trying to deliver. And the same applies to the health system. You can't manage a diabetic if you don't know their HbA1c, or worse, you have one but it's over 12 months old. So it's important to measure things and in terms of obviously things like vital signs and pathology, but also in terms of labeling diagnoses within your system and having the accurate information around medicines and other pertinent information, so that it all comes together in terms of that delivering that quality care in a safe manner. Often we find that when we do look at general practice information systems and their health summaries, they are unfortunately more often than not necessarily reflecting the current status of the patient in terms of their diagnoses and medications. Now, I know there's always some lag time, so if your patient's been in the hospital or haven't seen you may not have updated their latest medications and, or allergies or anything like that until you might see the patient. But at that point of care, when you do see the patient, it's an opportune time, every time, to just update that information so that when the patient leaves you, at least at that point in time, you have an accurate health summary around their medical conditions and medications. That once you start that process as a way of continually updating that information, is not as arduous as, say, when you haven't been doing it for many years and you end up having to spend an inordinate amount of time to try and clean up that medical record. I'll talk about that a bit later, about ways you can do that. But the most important thing is see information as critical to your clinical business that you deliver, and the way you may deliver your services to your patients, and ensures, I think, at the end of the day, a very high professional attitude towards patients. Because if you don't care about their data, one wonders whether you care about them. Is another motto that I've in the past as well. I'll stop there.
Yeah, now that's fantastic. Thank you so much, Peter. Now, I said just before, if data quality improvement's not part of an overall and continuous focus on quality improvement, then the practice is unlikely to achieve a sustainable digital health benefit. Patricia, would you like to add anything to what Peter has said just around the continuous quality improvement?
Sorry, I was just losing you a little bit there. I mean, I just think I would just endorse everything that Peter has just said. In my practice, I'm lucky that I have a nurse that's passionate also with this data quality issue. So she uses PenCat to run reports and do PDSAs for me, and then she runs these small reports in sort of bite-sized pieces and gives them to the doctors to show where there are sort of data quality issues. Like, for instance, if there was indicated COPD with no diagnosis, she would try and get small reports, because we found if we give the doctors big reports, they just get overwhelmed and they do nothing about it. But if we give them small lists to update and improve the data, that works in our practice. So the nurse would give the doctors these small lists and say, can you please go into these records and update this data and give it back to me? And then we sort of complete a cycle. And she has these Excel spreadsheets where she knows what report she's run, who she's given it to, if it's been updated and given back. And that's something that we've been sort of working on in the last sort of 5 or 6 weeks together. And it's a big task because I have 12 doctors in practice. But it is achievable if, as I said, if we do it in small bite-sized reports.
Yeah, that's a great point. I think that's really key, having those small, easy targets to meet. So that's fantastic, Patricia.
Thanks so much, Nikki. So Moving on now to medical terminologies, we know that it has been recognised that there is a need for the use of consistent terminology between clinical information systems, and free text terms such as high BP, for example, isn't understood by computer systems. So the use of standard technology really allows the system to easily interpret, or one system to really easily interpret another. And the use of standard terminology such as SNOMED and AMT creates a common language, allowing one healthcare system to really share that information and have information properly interpreted by that receiving system. So SNOMED has been endorsed by all Australian state and territory governments as the preferred national terminology for Australia. And as part of SNOMED is the AMT, or the Australian Medical Terminology, which provides a systematically organised computer-readable collection of medicinal terms, and these are modelled according to international terminology. So this information really is intended to be understood by both computers and humans, and this creates that interoperability throughout the standard shared list of codes for medications as well. So the National Clinical Terminology Service, or the NCTS, is clinically validated controlled terminology that covers a wide range of clinical specialties, disciplines and requirements. And this is currently operated by the Australian Digital Health Agency, and we're responsible for managing, developing and distributing that national clinical terminologies and related tools and services to support digital health requirements of our healthcare community. So do you know which software which terminology your software uses? And were you aware of these standardized terminologies? We also will provide a link at the end of the webinar on our website. So if you would like to join the clinical terminology community, you can do so. And there you'll be able to see recent updates and access all the latest information on the National Clinical Terminology Service product releases, and all the related news and events as well. There is in regards to that. And there are also CPD accredited courses related to this topic. Now, just in regards to the common issues that we're seeing with data quality, so we now know the importance of having high quality data, but what are some of the common issues that we're faced with data quality, and how does it really impact our everyday practice? Think about, have you ever had referrals returned to you? When you go to upload a shared health summary through My Health Record, for example, do you find it's just too difficult and time consuming because of all the uncoded data that you might need to be entering manually, or inaccurate information that's coming through and possibly conflicting details that you then need to sort through? So what is it in our everyday practice that we're finding is affected by data quality? And Peter, it would be really great if you could just discuss some of these common issues from a GP perspective as well.
Sure, thanks, Nicola. I think the first one, use of uncoded information, I think the key there is that is the last resort. So if the coding system doesn't have the code, now in SNOMED terminology, that's updated quite a lot, and that's a very large database of terms and everything else. But the coding systems that are in our clinical information systems, such as DOCL for medical director, or the PyFinch code for best practice, and the ICP +-2 or variants of that in some of the other common GP software systems, have got their own coding systems. Now, all of those coding systems, believe it or not, have already been mapped to SNOMED. So most of those can in future be translatable into a SNOMED terminology. But the key is to look up whatever that coding system, which is not complete by any stretch of the imagination compared to SNOMED, and by selecting the diagnosis that best matches whatever it is you're trying to put in the system for that person, rather than free texting. Now, diabetes is a good example, hypertension, hyperlipidemia, most of those common things, 95+% of the things we see in general practice are already in a coded form in our clinical information system. So it's a matter of just finding that and being consistent with that. The only thing I would suggest is that things like diabetes, don't just put in diabetes, because that could be, is it type 1, type 2, is it insulin dependent or whatever. So have a look and you'll see that often they've got diabetes as a code, but they've also got the other options, and it's a matter of being consistent in your practice which one you might choose. In our practice, we tend to select diabetes type 1 and diabetes type 2, or diabetes type 2 with insulin. And we just stick to those codes from the list that's available. So the key message is avoid uncoded information, simply because your decision support systems can't access that code. There's risk of you could mistype something as you're typing it in, and a whole lot of other things that may be difficult. However, having said that, because the coding systems are not complete by any stretch of the imagination, you will at some time have to enter a free text diagnosis. But it's the exception rather than the norm. As I said, the standard terminology is slowly working its way through into our systems, and SNOMED has been accepted as the Australian standard terminology. So it'd be worth getting to know what that looks like and how that is going to be implemented in general practice CIS. My understanding is that it'll probably, there's over 400,000 terms, and they'll probably digest the top 1,000 to make it a very easy routine thing. And if you can't find it in that first 1,000, then you go looking it up. But that's future. Too much information. I think the key there is often, as GPs, I've seen some practices where every medicine ever prescribed is still in the current medication list. That's not really very good and not very safe way of managing information in your systems. When someone's not on any medication, it's time to remove that medication from that. It's always stored in the old scripts section. If you want to look it up in some future time to see if they've been on a different or similar SSRI, you can look that up in the old scripts section. Too little or missing information, I guess we've been talking a bit of that, the impact being on not transmitting the right information when you're particularly referring patients. Inaccurate information, I find the best way to deal with inaccurate information is I give the patient, I used to give a patient a summary of a health summary printed off for them, and they could come back and advise me the correct date that they had their appendix out, or the fact that I've got a diagnosis on there that they're not on, or medication they're not on. And that's a good time to do that prior to uploading a shared health summary. Don't do it when you're trying to upload the shared health summary once it's launched into a format prior to the shared health summary being uploaded. Do it in your system, update your health summary, make it very clear and accurate, and then it's just a matter of a couple of clicks and it just goes up to the My Health record. You shouldn't have to intervene and remove or add information in that process. Anything that's confidential is the last point I'll make, because we could be here all night on talking about this, but anything that's confidential, flag it in your system as confidential. It then doesn't appear on referral letters, and it doesn't appear on a shared health summary. Again, you don't want to be ticking things off once you've launched a shared health summary prior to upload and having to untick or tick things in, or which all you can do is untick really. You really don't want it there in the first place. If it's confidential, make it confidential in your system, and then a shared health summary, again, is just a couple of clicks and it just goes straight up. Clinical information system usability issues, that's another topic in its own right. A lot of our systems are not necessarily the most intuitive in terms of data capture. And there's always room for improvement. And if you've started 20 odd years ago when I did, the systems are getting a little bit better, but probably I think a lot of them are just getting a little bit clunky as well in the process. Poor data capture interface kind of relates to that issue. It'd be nice, in future where you have a little barcode scanner, scan the vaccine, it's automatically in the system, or your blood pressure reading automatically is uploaded into your system through Bluetooth connection or whatever, rather than us having to type in things. Because every time you type in, it's an extra step, and it's a risk of transcribing the wrong thing in that process. So they're all future things in some ways that that are slowly coming into our clinical information systems. I'll stop there.
Thanks, Peter. And as you mentioned, we could certainly talk about this all night, which is why we have split this topic up into a two-part series. And many of the things that Peter just talked about there and some of those strategies we do sort of go through in a visual sort of walk through on our next session. So be sure to join in to part 2 where we'll get the opportunity to kind of flesh that out a little bit more. So moving on to the RACGP standards. Many of you know that the RACGP have set standards for data quality in regards to accreditation. And some of us might look at this and be a little concerned at first, but what we find is that in order to achieve these benchmarks, it is sometimes a matter of breaking it down into smaller tasks, and in order to accomplish these sort of wider benchmarks. So exactly what Patricia sort of mentioned earlier, and an example of what that might look like is, for example, a quality improvement activity for getting our allergies status up or getting the proportion of allergy status recorded higher. We could work on, for example, just our diabetic patients to start with. And then once we've completed the quality improvement for that particular patient group, we could then move on and progress on to the next achievable outcome. So that way we're achieving sort of measurable and smaller goals, which will then contribute to a larger improvement in our data quality. And of course, it is preferable for the practice to use nationally recognized coding system rather than a system which is distinctive to each individual practice. So as we mentioned before, coding does not necessarily need to replace details in past medical histories that have been recorded in free text. It should be seen as a useful addition to comprehensive past medical history. So certain aspects of a person's past medical history may be really difficult to formally code, and this is exactly what Peter mentioned in regards to making sure that information is determined according to that individual patient. And consistent coding and terminology should be used in consultation notes as well to support continuous quality improvement and clinical care and better patient outcomes as well. So Patricia, while we're talking about standards for general practice, could you give us any hints or tips in your experience of how you managed to achieve these standards or these benchmarks for data quality, and what you would advise of other practices who may be working towards it?
Okay, I mean, if I look at something just like the first one, which is the allergies, for me, I've been through sort of 4 accreditations, and I tend to do it as a whole team, so everybody sort of gets a task and everybody's involved. But I would get an admin member to run a report on PenCat to look at the allergies, and again run those small reports, give them to doctors, put reminders into those patients where this information is not updated correctly, and just involve the whole team to try and achieve that improvement quality. We sort of do them as PDSAs and just try and involve the whole team. And that has worked for us, doing just that one example of looking at improving the amount of allergies that are recorded.
Thanks, Patricia. So the QI PIP, or the PIP practice incentive payment quality improvement, may be familiar to you as well. And this is essentially an incentive that rewards practices for participating in continuous quality improvement activities in partnership with their local primary health network. And so practices get to choose whether they or where they focus their quality improvement activities. And there are specific improvement measures which we'll look at in a moment. But for practices who are involved with this PIP, there are no set targets for improvement measures, and practices can choose to focus their their activities on whichever area they prefer. But what this does say is that the areas must be informed by their clinical information system data and meet the needs of their practice population. So that's certainly a really good thing to keep in mind. And so looking at the quality improvement measures themselves, we can see that quality improvement is foundational to contemporary high-performing care. And as Patricia mentioned, it includes team-based approaches, as well as peer reviews, reflective practice, best practice, and data analysis. And it can improve the uptake of evidence-based practices for better patient outcomes, better professional development, and better system performance. So the collection of all this de-identified data within these improvement measures that form the PIP eligible data set are actually part of a system of quality improvement that includes reflective practice, a common data baseline, and data analysis. And the improvement measures are not designed to assess individual general practices or practitioner performance. They do support a national and regional understanding of chronic disease management in areas of high need, and future iterations will respond to the emerging evidence on areas of high need. So this really highlights the use of different coding or the problem with the use of different coding and terminology across general practice clinical information softwares, and how that could make it really difficult to transfer, compare, and analyze data between systems, because now we're looking at it on a population health basis. And this is a barrier to effective data exchange and semantic interoperability, as well as research and quality improvement as a whole. So any activity targeting data quality can be designed as a quality improvement activity. Doesn't need to be one of these, but provided it just needs to be an activity that's planned and documented in order for it to qualify for the PIP-QI payment. And many of the practices are working with their primary health networks in order to achieve these quality improvement activity goals. So Patricia, while we've got you on the line, could you talk about your experience with the QI PIP and sort of ways that you've utilised this in practice?
Yeah, so again, I know that I keep saying this, but I try and involve the whole team. So we have a list up on the in the staff room on the notice board of anybody that can see where there's a PDSA. And I mean, if you look at COVID, there were probably 30 PDSAs that happened during COVID, like from putting the screens up for, that was one PDSA, getting a hand sanitizer station at the reception. So it's not, as you said, it's not just these 10 measures, that everything that you do in general practice, you can look at, is this a quality improvement? And for me, it's just about documenting. We have PDSA templates on all of the admin computers, and the staff will often just come up with one and say to me, here's the PDSA that I did today. So it's just about involving the team for me, because it should be a whole practice thing. It's not just something the practice manager should have to do. I mean, doctors should be involved in that too. You know, we get the PIP that comes to the whole practice. So for me, it should be a practice incentive, not just something that the manager has to be involved in. So, you know, I've got a whole booklet, all of the quality improvements that we make, so that if we're ever audited, I can say these are all of the quality improvements that we have done in the practice, including all the ones since the beginning of COVID, you know, so over the last year, all the things that we've done to try and improve, you know, patient care around that are included in it.
Thanks, Patricia, and that's really great to hear. I was just going to jump in there, Nikki, and say that's amazing that you've got staff coming up to you, handing you a PDSA that they've done on their own accord, because I'm sure that's sort of the goal of where we're all getting to take ownership. That data quality is everyone's business, and that's really awesome to hear.
Yeah, I was going to actually mention that too. I think that's fantastic that you've been able to achieve that.
I mean, I'll just give you a little example about one PDSA. It was at the beginning COVID, when we were looking at how do we, protect the staff, how do we protect the patients. It was a staff member that had seen a picture of some screens. She knew somebody that was really handy that could do the blocks to hold the screens. She went to look at where she could get the perspex to get the screens made. And, it was, with my input, but it was something that was initiated by a receptionist. So
yeah,
I think that's just,
it's fantastic, isn't it? That's really utilising a whole of practice and utilising and recognising everyone's contributions to making quality improvements. So yeah, that's perfect. Thanks so much, Patricia. That's really, really good. So let's move now to the essential summary clinical data. And you can see here on this slide, there's obviously 4 types of that essential clinical data that should be captured in a patient's My Health record. But there's obviously more to that than just the 4 types. There's a lot more that contributes to that clinical data set. So Peter, would you be able to now talk us through the essential data and what actually goes into that, and some of these other areas that we should also be looking at?
Sure. Look, the 4 highlighted areas, the current medications, medical diagnoses, immunisations, and the allergies, that those 4 form the very basis of a shared health summary that is uploaded on behalf of patients to their My Health record. So in some ways, they're the minimum essential information that's obviously important in terms of clinical decision making. The reason for the prescription, you can add that as a comment in your clinical information system, and that does come across into the shared health summary. So I would certainly, any medications, if you can put in a reason for that prescription, it would be very helpful, not just for the patient, but for our colleagues when we're referring patients as to why a person may be on. Some is obvious, they're on a blood pressure tablet, it's for blood pressure, but it might be a low dose ACE for heart failure. So the reason you're putting it in, the prescription is important. The allergies and adverse reactions, often you can add additional information, obviously in terms of the nature of that reaction, and being very clear what is an allergy, anaphylaxis type response to something versus just a side effect or a nasty side effect adverse reaction that one would expect from that medication, but nonetheless we should still avoid. Immunisations, ideally, certainly on our system, should include the batch number, and if they're things that you have to give a series of vaccinations, which sequence it is. And lastly, I think, again, a lot of this would be part of what we might see in the RACGP health summary, which would include other things from family history and other lifestyle issues, as well as some what I call very basic vital signs. You could add blood pressure to that as well. All important information, but this is kind of that core information, which I know in medical director and best practice, you can there is a tab that you can have, and you can have these all laid out, the basic clinical health summary information at a glance. I think that one of the things, and this is summary data we're talking about, just back to that previous slide, very clearly you need to be recording this sort of information to be able to do the quality improvement PDSAs, whichever one you choose. But remember, even those PDSAs are very rudimentary. They're all more about getting things done. So diabetics having a hemoglobin A1C in the last 12 months, and if they haven't, why haven't they been done? There are gaps in service provision. Versus the next level of that data would be what percentage of my patients have a hemoglobin A1C greater than 8%, and you want some benchmarking, so compare your practice data with others, and we did that in the big diabetes trial, or going back about 8 years ago, where we had all that information, and it was interesting. It wasn't used in any punitive aspect, but I tell you what, it encouraged a lot of practices to take that population perspective and sort out these patients who are travelling on hemoglobin A1Cs of 8 to 12% and not being reviewed or not having the right interventions or starting insulin or whatever. So you can see that data will drive a lot of additional kind of things, all about improving patient outcomes and all about improving the safety and efficacy of the work that you do in providing good quality care.
Yeah, thanks so much, Peter. All right, so thinking about everything we've just heard now, let's have a think about now clinical risks of poor data. So clinical risk management is a process of improving the quality and safety of healthcare services by identifying the circumstances and opportunities that put patients at risk of harm. And Peter just spoke about that then with the diabetic patient. And then acting to prevent or control those risks. Now, this comes from the Standards for General Practice 5th edition from RACGP. Now, this is our test patient. Now, we've used Mr. Harding, his clinical data throughout this presentation. So we are aware not everything's going to be perfect, but it's just for simply the purposes of demonstrating some of this clinical information so that we can show you what's good and how to fix that up. So I guess looking at Mr. Harding, we look at his current diagnosis, so what's current, and then his past medical history. So his current is type 2, hyperlipidemia, hypertension, GORD. He's got, as a past medical history, DVT, UTI, hernia, and childhood asthma. So considering Mr. Harding's profile, you can see here information showing old scripts that are marked in red. Now, these are either no longer used or they've been ceased. However, you can see they're still sitting in his clinical file and listed as current medications. These really should be moved to past prescriptions. But what's the problem with that? And Peter just mentioned sharing this information. So for any auto-populated documents, like your shared health summary or your referrals, these documents will contain this same list of medications, even though you know that they're not current. Now, additionally, there's some conflicting data. There's an adverse reaction to taking ramipril. However, it shows there's an allergy to the medication. So it shows the allergy to the medication, but it's still showing in the current medication. And again, this information would be shared in any shared documents. Now then, Peter, looking at this clinical data in Mr. Harding's file, and I'm conscious that we're getting very close to time, would you be able to just quickly go through with us looking at the active problems and highlighting just quickly active problems versus inactive problems?
Sure. I think the important thing is, and certainly in medical director and best practice, you can separate out things that are inactive, such as past events or conditions they've had and that are resolved, or procedures are a classic example of in the past. So in this case here, you can see at the bottom the inguinal repair. First of all, it's a duplicate, and so that will appear twice on the summary. Looking at the date, one might assume that it's the same thing and just been entered twice. I see a lot of records where, for example, hypertension is entered as reason for visit and ends up in the diagnosis list. So over 20 years, you see hypertension 50 times and they're just stuck there. You only want it once and the date it started. That's important. Things like a fingernail removal, that would be a past procedure. That should be inactive. And you can still have that on the summary if you want to. Things like diabetes probably need to be a bit more explanatory. Is it type 1 or type 2? And if it's type 2 and they've got insulin, then you know it's moved on from type 2 diabetes to requiring insulin. So just a bit around clarity around which ones are active and which ones are not. And just expanding on things such as the diabetes one, or the other one is pain, chronic pain. I mean, it could be a chronic pain syndrome, could be fibromyalgia, could be a regional pain syndrome. The more specific and the more the diagnosis explains itself, the better. but separating them out into past history and, in other words, active or inactive, and avoiding duplications or triplications in some cases or more, and being a little bit more specific around the diagnosis so that one reading it is clear that, with, for example, diabetes is type 2 and not type 1.
Yeah, thanks, Peter. And so I guess then you just mentioned before that there's a duplication of the hernia, and obviously not only do you have inactive conditions, but there's also uncoded, and you mentioned the diabetes and the pain. So yeah, so we can see that in this slide as well.
And high BP
So,
really should be hypertension as well, you know.
Yeah, that's right. So there was quite a number of things in there that we need to consider. You know, recording correctly, coding it correctly. So, but the implications for that information. So again, Peter mentioned before, uploading the shared health summary, the information that you're sharing. Now, because you have, you're preparing the shared health summary, and you can see this is the first step. Now, the shared health summary captures that patient's health status at a point in time. So this is Frank's health status at a point in time. And often this is the first document that another healthcare provider may gain access to get an overview of Frank's health. So when the clinical information in the patient's file is not kept up to date, there is a potential of providing inaccurate medications, as you can see here. So if you don't or deselect it in this view, and again, Peter did highlight the fact that if you've done it already in your clinical system, in your clinical file, it will be a simple process here. However, in this example, it's not. So you would have to deselect it. You'd also have to consider the medication that's actually been ceased. You've also got conflicting detail with medication that's in adverse reactions. So I guess we have talked about the implications for this. So, you know, sharing this information for a provider, Peter, what would be the clinical implications sharing this information as it is now?
Yeah. Well, there's a couple of conflicting information there. One is things like ramipril, which we know was ceased 3 years ago. I think it was 2017. But also ramipril as an adverse reaction. It's probably not an allergy to ramipril. A cough could be something that just is a known potential side effect of ramipril through a different pathway to anaphylaxis. But nonetheless, you've got severe cough, probably angioedema, who knows, maybe it needs to be a bit more explained there, but it's already sending the wrong signals to another provider. It seems to imply they're still on ramipril, and yet they have had a significant adverse reaction to ramipril. Plus things like, I think it was pantoprazole, you know, that was ceased 3 years ago, and again, you may get the impression that this person has got gastroesophageal reflux. That's active, and that would make a decision maybe from, if they took this at face value, may alter their decision making about what they might do next or prescribe next. So look, fix this up in the clinical information system. This is just a preview before you upload. You shouldn't have to touch anything here, and that's the way I would recommend everyone does it. It makes it easy, because the future may well be that you will automatically upload shared health summaries with probably just one click, without going through this step of the preview, knowing that your health summary that's it, that's what you understand it to be, and just upload one without going through this step.
That's right. And then also considering that if you were going to be reviewing this yourself as a clinician and this was inaccurate information, so there's quite a bit in that. And then I guess this is the shared health summary.
And I think the point to make here is that you can see, unfortunately, the diagnosis list doesn't separate out into past or inactive, which is a limitation and concern. But if you can add comments to things in the, that's what I would do. So some of these things, the fingernail removal is going to be obviously a past procedure. Childhood asthma could imply it's all resolved. This person's now an adult. There's a lot of things that still need to be tidied up, I think, in terms of separating these items into inactive and active.
Thanks, Peter. Nikki, are you able to move to the next slide for us? Thank you. So just in regards to that final look, not only does it affect shared health summaries where providers are accessing patients' records or my health records and viewing that inaccurate or out-of-date data, if we're sending a referral to a specialist or to another practitioner, how would that reflect on me as a provider, and how would that reflect to the patient as well? And Peter, I know you talked about this already, so I won't spend too much time on it, but if the patient was to go away with this referral in hand, what would they think? Some of this stuff being quite old, some of it not being detailed enough, and some of it being, inaccurate, where we've got medications that they're not taking, which I'm sure would be of concern to some patients. So really thinking about the implications of that data to the patient safety, but as well as to how it reflects professionalism at the practice as well.
Okay, so let's go through Mr. Harding's clinical file and now looking at what it looks like with accurate clinical information. So before we asked Peter to go through the active and inactive, so now this looks a far better, clean and more accurate, up-to-date clinical file. We can see all the active problems, we can see the inactive, and we can also see that there's been consideration given to the clinical relevance as to whether the information, as Peter said before, should be or shouldn't be included in a shared health summary or in a summary or any information that's being shared. So in this indication, we said the fingernail removal wasn't going to be clinically relevant to share, but we did feel that the DVT was relevant. So that thought as well to choose that inactive information as to whether you want to share that in summaries, and that can be done easily. So again, spending time keeping your patient's files up to date helps save time when sharing information. And Peter said before, it becomes easy. You can be confident, you click, you can share that information in a couple of clicks and it's done. So you're confident that the information shared is accurate and it's up to date. And again, once you've spent the time updating your patient files, it ensures that clinical information that's shared with other healthcare professionals helps facilitate safe and effective care. And of course, it shows the highest possible quality and that's relevant to your patient's ongoing care. So we are going to have, as Bree mentioned before, and obviously as you've heard tonight, there's a lot of information to go through, and it's been fantastic hearing from Peter and from Patricia about some of the tricks and tips that you can go through. But we can do this we're going to show you this in the second part, and there we'll show you how to record a diagnosis, how to correct that medical history, use terminology that's available in your clinical information system to code the medical condition, and we'll also demonstrate how easy it's going to be to correct that uncoded diagnosis and the correct use of free text. And we'll also show you how to update prescription information and add detail to that quite quickly as well. So that will bring us now to our panel discussion for the evening. And we do have a couple of questions there, but I'll just get, if you don't have your webcam on, now hopefully this will work for us. We have had some trouble with our network, so let's hope that works. We do have a few questions, and Peter, actually the first one is for you, and it simply is, Peter, in my clinical file, there are often a lot of inherited uncoded problems. Is it possible just to draw a line in the sand and go from there?
Well, depending on the system you've got, as I said, a lot of you could go back and either just make it all, make it all inactive and not for your summary, right? That's one way of. You still need to do something, because if they're there as active items, they'll appear on your referral or upload in a shared health summary. So I've unfortunately get that exact problem not infrequently. I have some colleagues that unfortunately just don't seem to follow some of the rules that we've put in place in our practice alone over the years, and that is to clean that data as we go along. So I've had many patients where I just have to just sit there, look at the data. I can see, not even diagnoses, just phone call, letter sent, reason, cough, you know, all that sort of thing. And I could spend 5 minutes cleaning up some of those files. And I do it deliberately because if they want me to continue with their care, I don't want to be continually disrupted by all this irrelevant noise in my system. So you can draw a line in the sand, but my view is you're going to need to clean that data up one way or another. And if you want to keep it for historical reasons, just make everything inactive and not for summary. But if you're going to go to all that trouble, just clean out the duplicates and find out what's relevant. The other thing to do, I think, to prevent it continuing on, and this is what we've done in our practice, is to, in medical director, and now it's taken them a while, but I've convinced them, and a few others have convinced them, to not have the default reason for consult to go into diagnosis. So that was the default setting. It's now no longer the default setting. If you want the reason for consult, and the reason, it'll save that in your progress note, but if you want that reason, e.g. it might be that you've diagnosed hypertension today and you want that reason, hypertension, to be the first time to be added to the health summary, sure, tick the box, it's one tick, but at least it eliminates all those reasons for visits, including phone calls and whatever, away from that health summary diagnosis.
That's great. And we will definitely be going into that in more detail in part 2. So whoever asks that question, please join in for our next one. And hopefully we've got time for one more question. Patricia, this is really for you. I'm trying to improve data quality, but some providers in our practice aren't interested. Do you have any tips for them on how to encourage their providers to help and start cleaning up that data? You might still be on mute. Sometimes it happens in 2 places, and I've got caught with that myself.
Is that okay? Can you hear me now?
Yes, yeah, that's great. Thank you.
We are lucky that we do get a lot of uptake of our meetings. So we have regular practice meetings. So we have practice meetings where we invite some of the admin staff, the nurses, the partners, the associates, and in those meetings we try to look at the problems around this and how we get around it. And also, I think when our nurses are doing health assessments or care plans, they're very aware of if there's data that needs to be cleaned, and they'll often go and talk to the doctor and say, look, are you okay if I do this, that, or the other? So we try and involve the nurses, and then they can talk to the doctor. And I think also, like, we've just had a new doctor started, and I think when you were saying before, Peter, about a line in the sand, is like any new doctor that starts, I try and get them off to a good start as doing the right thing from the beginning. Like, we try on the user preferences to clone the preferences so that they're all trying to do the same thing, because otherwise that's where the issues occur, is that their preferences on their clinical data is all different, and then it pulls through differently into the shared health. Sorry, I was going to say, we do get resistance, like I'll change it and then I'll say, I don't like the way that's set up, I want it my old way. But, you know, that's the hard thing. It's trying to get consistency around that data, because when you're a computerized practice and doctors all work differently, that's hard when you're trying to, you know, look at that file when the doctors are all working in a different way.
Yes, exactly. And that's, I guess, we're very lucky for our part 2 to not only have Dr. Peter Del Fonte join us, but Patricia as a practice manager, and some of those tips you just spoke about we'll be able to cover again in part 2. And so we are very lucky to have both of you being participating in our next one. And some of those tips and tricks about how you can set and clone that information to make sure that the settings are actually done is really important, and that's something we'll definitely be looking at in part 2. So just to finish off for tonight, we've got a data quality checklist. Now, this checklist is really handy for you to go through to help you with the data quality, and it's available on our website. And we also have some useful resources, and there's some RACGP improving data quality and a few things, and especially the SNOMED and Australian in Medicine terminology. And we've also got the Primary Health Network locator. And then, as I've said many times, don't forget to join us for part 2. And again, we're really grateful to have Peter and Patricia, and thank you so much for your input tonight. That has been invaluable, and I certainly hope that everyone listening got heaps out of it. I certainly did, and we really look forward to having you for our next session. So thank you all very much, and please complete the evaluation at the end of our session tonight. And good night. Thank you.
Thank you, Nick.